I'm going to introduce you. Please forgive me if I get any of the words wrong, and I may come to you to say the big long ones for me. So Tony Goldstone is the principal investigator and head of the Psychoneuroendocrinology Research Group. Is that right? In the Neuropsychopharmacology Unit. That's right as well, isn't it? I can tell by your smile. Centre for Psychiatry, Division of Brain Sciences at Imperial College, based at the Hammersmith Hospital, London in the UK. He attended medical school at Cambridge and Oxford universities and worked clinically as an adult consultant endocrinologist at Imperial College Healthcare NHS Trust, London. He's a fellow of the Obesity Society, has researched and published widely on neuroendocrine and metabolic abnormalities in Prader-Willi syndrome and early onset morbid obesity, particularly investigating the causes of hyperphagia and obesity through clinical, post-mortem, animal model, genetic, interventional, fat and brain imaging studies. He's, I've lost my place now, I'm so sorry. His current experimental medicine research uses multimodal phenotyping, including functional neuroimaging, to examine body-brain interactions in the regulation of eating and addictive behaviours, with interventional studies including appetitive gut hormone administration and bariatric surgery. Tony runs specialist adult clinics for genetic obesity, including Prader-Willi syndrome. He was scientific co-chair of the first International Hyperphagia Conference in 2009 and has been a member of the scientific committee for the second PWS expert meeting in Toulouse, France in 2006, 6th PWS International Conference Romania in 2007, 2nd International Hyperphagia Conference USA in 2012, 8th PWS International Conference UK in 2013, PWS Expert Meeting France in 2014, and has been a member of the Scientific Advisory Board, Foundation for PWS Research since 2014. Tony, that is the most epic introduction with very long words. I would now like to hand over to you. You just need to unmute yourself, my love.
I thought you
There we go.
Oh, there you go. Right, thank you. Thank you very much for inviting me today. Shame not to be with you in person, but hopefully next year, sometime soon. Let me share my screen, which hopefully will enable me to do things. Good. Can you see that all right?
Yes, we can. We can see that. Lovely.
Okay, lovely. So it's a pleasure to be talking to you today. For those who attended last year, you may have a bit of deja vu because I'm going to talk very similarly, but I know there's lots of new people who are likely to be joining. And I've got a couple of new things to mention just at the end on the basis of some recent papers that we've published amongst a consortium of adult endocrinologists. I'm going to cover some general things and I'll try and leave as much time as possible for questions because that's often where a lot of the interesting things come by. So as you know from that introduction, I run a clinic for adults with Prader-Willi syndrome in London. I look after about 45 patients at the moment. I do have to be a little bit geographically restrictive, unfortunately, because otherwise I'd be seeing far too many people than I can cope with. But hopefully we've learnt a lot about what we need to do with adults and the sort of general screening that we need to do to pick out problems and to think quite broadly outside of just the overeating and the obesity, because there are in this syndrome many body organs and body systems that are affected. So I use as the basis of my talk, just as a review, a little bit old now, but just a review of the sort of clinic patients that I see. And we had a very good student a few years ago who reviewed what our clinic patients were like to get some idea of the problems that we see. So at this stage, we'd seen about 32 patients. I said it's more now. Average age, about 26. That is getting a little bit younger now because now we are getting referred patients through directly from the pediatric services in a sort of transition phase, certainly younger. The oldest was 49. Haven't got anyone over 50 yet, but certainly there are more also appearing in that older age range. Being a London-based service, a wide range of ethnicities as would be expected. As I said, the first age 20, but now that's going down and probably will continue to drop now that we take people in transition from the age of sort of 17 or so. About half a deletion, that's less than in the general population, and that may be due to the fact that some of the patients with more behavioural issues related to uniparental disomy that Tony may have mentioned in previous talks, maybe they are more likely to get referred to my clinic because of behavioural issues that are affecting management. If we look at the sort of diagnostic criteria for Prader-Willi syndrome, which are sort of split into major and minor criteria, they meet the classical characteristics of people with PWS, as we'd expect. There is the odd person who doesn't have marked hyperphagia or obesity. So, there's a few patients who don't have that as a major problem, but by far the majority do have issues with hyperphagia and obesity. And in terms of the other problems, a spectrum of issues that we expect as the diagnostic criteria in Prader-Willi syndrome. And then we have sort of other features that are commonly seen, such as high pain threshold, decreased vomiting, temperature dysregulation, which is always quoted, but we don't actually have many people in whom that is a particular clinical problem. Scoliosis obviously being a problem. Osteoporosis, a fifth are presenting to my clinic with osteoporosis. One hopes now with better pediatric management and institution of sex steroids more commonly, hopefully that number will go down. We will have to wait and see about that. Several years ago now, it's shocking to see how long ago this was last written. We did some guidelines. We are actually writing some pediatric and transition guidelines at the moment in the UK, which hopefully will be published soon, which will update these recommendations to the management. And if we look at the major recommendations that we had then, which remain very much the same, the basis of management in adulthood needs to be still control of the food environment and regular exercise. It's been very interesting to see over the pandemic and with lockdown and the loss of access to gyms and pools and regular exercise that we have unfortunately seen a lot of weight gain. That's also been balanced by the fact that obviously with being inside the actual, in some ways, control of the food environment has sometimes been easier because there hasn't always been the access to food. But I think on average, it's not been a good thing because of the loss of activity. And so hopefully that's now, as lockdown has ended in the UK, going to reverse itself and we can get back with people having regular activity, which is really important. And we have, as Tony I know has talked about in other sessions, the difficulties when we handle this transition from adolescence into adulthood and the increasing demands for some independence, how that can sometimes conflict with management of the access to food and weight control. Group homes remain for many an important part of the management, and many of my patients who've had difficulties controlling the access to food and weight gain in either the family home or in supported living or non-specialist Prader-Willi homes have done very well in residential group homes, and I have several patients for whom it really can be said that it's been life-saving. And also by providing regular physical activity as well, that they can really be beneficial. It's important to be having an early institution of a low-calorie, well-balanced diet with appropriate counselling of the patients and families, and hopefully that commencement in childhood can lay the foundation for adulthood. But obviously, as patients sometimes are seeking more independence as they come into adulthood, that can be tricky. The exercise is vital, as I said. Growth hormone does not affect the drive to eat, but it certainly can help body composition to some degree in terms of reducing fat mass and increasing muscle mass and enabling people to do more and be more active. Every year we're having new drug trials that are going on with new medications. Unfortunately, nothing licensed yet. We've had 2 or 3 trials that have reported recently, some not successful, such as unfortunately levolitide run by Melendo. The carbetocin, oxytocin analog was moderately successful, but unfortunately FDA reviewed that recently, have not suggested that will gain approval, but there may be more data coming. And then we also have the Destiny trial of diazoxide, which has been a bit more encouraging, and there's ongoing open label study of that, which hopefully we'll be reporting soon. And there's at least 2 or 3 other trials planned or ongoing in the UK and Europe in the future of new potential drugs which may be beneficial. So, you know, we haven't had an awful lot of successful trials, but hopefully some will be beneficial in the future. Ones that certainly have not been beneficial are these, including drug setmelanotide that is mimicking the effects of alpha MSH, which is a hormone in the brain that reduces appetite. This desacylghrelin, unfortunately unsuccessful. This inhibitor of ghrelin, which stimulates appetite, that is raised in Prader-Willi, unfortunately also not successful. We've had successful drugs, so there are drugs that do have a significant effect reducing appetite, but unfortunately the 2 that have been discovered so far from trials had unacceptable side effects, either psychiatric or blood clots, and clots on the lung, pulmonary emboli, needed to be withdrawn. GLP-1 analogues, a trial finished, liraglutide not yet to report. There are newer versions of these drugs, so these are hormones that act to stimulate insulin, have been used to treat diabetes but also reduce appetite. There is a newer version called semaglutide, which in people without Prader-Willi syndrome is really producing 20 to 25% weight loss on average. We don't yet know if that's going to be tried in Prader-Willi syndrome as a trial, but I suspect we may see some people trying it in smaller trials as opposed to drug company trials, and it may have some benefits. As I said, intranasal oxytocin had some effects, and also some effects on behavior, but not licensed yet, and they may need to gather more data. As I said, diazoxide looking promising, acts in the brain to suppress appetite, and there's some encouraging data coming out from this trial, and we wait to see if and when that will get a license sometime soon, or whether further trials are needed. And at least one trial starting soon of this double drug, which acts on various brain chemicals, as well as another drug to prevent increasing heart rate or blood pressure. So that will be starting soon. There's other trials being planned of cannabidiol, the psychoactive component of cannabis, which may have some benefits on both anxiety and appetite, and there's also other trials of a few other agents being planned. So the landscape is very encouraging, and hopefully some of these will prove to be successful and give us some extra tools to treat the appetite. In my clinic, about 41% have diabetes. Again, that's probably an exaggeration of the true prevalence of diabetes because of the referral bias to the clinic. We have a number of agents that we can use for treatment of blood sugars in Prader-Willi syndrome. I have to say that often when blood sugars are not controlled, it's often due to the fact that there's access to food. And I've had patients who've been on multiple agents, including insulin, who actually, when we have managed to get them to move to a specialist Prader-Willi syndrome home, have been able to dramatically reduce their insulin requirements by sort of 3/4, or even often come off insulin and often many other drugs. And so indicating that the poor sugar control was primarily driven by the excess food intake. And I think that sometimes that's underappreciated by diabetes doctors who don't have a particular expertise in Prader-Willi syndrome, because they focus on what we call insulin resistance, or making the insulin more effective, or giving insulin, as opposed to controlling the access to food. There are a number of agents which are beneficial in terms of also helping to lose weight, such as metformin, these GLP-1 analogues such as liraglutide, and also the newer one, semaglutide. These drugs, SGLT2 inhibitors, they basically act on the kidney to make people pee out more sugar. There's a little bit of concern with those as to whether they may increase the risk of urine infections and thrush, particularly in women. And I've had a couple of patients in whom that's been an issue, but I've also had others in whom that isn't. There's also now increasing evidence that these medicines are very good for preventing heart disease and also kidney disease in people with diabetes, and they're becoming increasingly used, and they're actually even now being used in people without diabetes with heart failure, because basically they cause a bit of a diuresis, water being peed out with the glucose by the kidneys. The DPP-4 inhibitors are weight neutral and can be used. Pioglitazone, a drug that improves insulin sensitivity, not often used in people without Prader-Willi syndrome. I've actually had some benefit from it because it does treat the insulin resistance, but it is known to be at risk of causing weight gain. I tend to avoid the sulfonylureas, that's drugs like gliclazide or glibenclamide, because there is a risk of low blood sugars, which then cause the overeating. And also I try and avoid insulin as much as possible. And there are very few patients who really need insulin in my experience. And certainly short-acting insulins can be a problem, because low blood sugars really then result of a need to eat more, increase calories and causing weight gain. So I think we should be trying to avoid these as much as possible. Certainly as patients get older, we may need to think about having cholesterol lowering medications, although actually people with PWS seem to be protected against getting particularly high cholesterol and high triglyceride levels, and so it isn't that common that patients need these. But certainly once they're hitting the age of 40, we would consider those if they have levels that are above guidelines. When we look at the placement of the patients that we were looking after at this stage, 35 patients and we classify them as whether in the family home, supported living, non-specialist residential homes or specialist residential homes. If we look at the change in their BMI as we follow them up in those various placements. So this is where they start and this is where they end up. So in the family home, things generally reasonably stable, but obviously those are people for whom they were doing reasonably well, but certainly some are gaining weight. Those who gained weight and moved to supported living, in our experience, did not do very well. Those who started in supported living and stayed in supported living, again, stable, but again, that's a bias because that's why we were able to suggest staying. And the one patient who moved into a non-specialist residential home gained weight. Moving into non-specialist residential homes from family homes, a big variation in change in weight, but certainly some did not do well and gained a lot of weight in non-specialist homes. And then patients moving into supported living or staying in the specialist home, some did reasonably well, but by far the better ploy was those who moved from the family home or non-specialist residential home into specialist residential homes. And I've certainly got many more patients since then in whom this has been very beneficial. Unfortunately, we're still undersupplied with specialist homes. This slide courtesy of Miles Kelly from Consensus, showing the distribution of homes, certainly a deficit of homes within the southwest, deficit of homes within London itself. We have one home in London, the rest being outside, and a bit of a lack in the northeast and northwest. And there are 6 main providers for these homes, and obviously the geography and wanting to be close to family and friends and community and churches, etc., can be an issue. And as I said, they are expanding, but certainly there are some areas that are under-resourced around the country. Just to give a few examples of the benefits of the specialist residential homes, a few case reports. So this is a patient who had diabetes, gaining weight in the family home, moves into a specialist residential home, and really life-changing from a BMI of 60 down to a BMI of 35, and subsequently has gone even lower. They were also on an awful lot of diabetes medicines, 5 diabetes medicines, with still inadequate control of their sugar. This is the HbA1c, the average sugar. This is normal, and you can see their sugars were still very large, needing more and more insulin, into the specialist residential home and basically cutting off the food intake, able to come off all their medications, just leaving them on metformin, the only agent off insulin, and now normal sugar control. So really emphasizing the importance of control of the access to food to control the sugars. Another patient in the family home gaining weight, moving into a specialist residential home, really successful for weight loss. Occasional trips home to the family home, weight gain, and that's certainly something we see, but we accept that, and they lose it again when they come back. Just demonstrating person injured themselves and had a reduction in physical activity, and that was associated with weight gain. So very sensitive to weight gain. Similarly here on insulin, needing lots and lots of insulin, managing to improve the sugar control markedly as they lose weight and controlling the access to food. Again, with a period of poor physical activity, sugars increased again, demonstrating the importance of maintaining good physical activity. This is a non-specialist residential home, patient in the family home, gaining weight, BMI up to 75, into a non-specialist residential home. Initially did well, and that's often the case, but unfortunately wasn't sustained. Problems in non-specialist residential home, often a turnover of staff, staff maybe not being as experienced, went into supported living, lost some weight, but again gained it again, and unfortunately funding for specialist residential homes are refused, and a lot of my time is being spent at the moment trying to persuade the CCGs that provide the NHS funding that often is needed along with social care funding for specialist homes is sometimes difficult. We've been successful in some appeal cases, and we have maybe precedent now to prove that it's not only for treatment but also prevention, but there's still a lot of hoops we have to go through to get that funding, which is real shame because this is a need for patients that is life-saving. Again, another patient gaining weight in the family home, into a non-specialist residential home, continuing to gain weight, increasing physical activity after an injury, lost some weight, and then really able to lose it in a specialist residential home down to a normal body mass index. And then finally, another patient now talking about prevention. So a patient with very normal weight at the age of 16, progressively gaining weight as they finish school, and so sort of the structure to the day lost, gaining more independence, able to gain access to food, becoming obese. So the patient is going to continue to gain weight. We had specialist funding refused because they argued that there wasn't a need at this case, and they really didn't seem to understand the need for prevention. After about a 3-year process of appeal, we did finally get an independent panel from the CCG to approve funding for a specialist residential home, and that hopefully will provide some of the data and sort of quotes that we can use, that even when we're trying to prevent obesity, that the specialist homes are needed from a medical point of view. And in fact, NHS continuing healthcare funding is supposed to also not only be for treatment of illness, but also prevention of medical problems, as in this case. But a lot of hoops had to be gone through in order to achieve that. This is also demonstrated in other countries. This is some data from the Netherlands, an adult clinic in Rotterdam, where they divided their groups up into Prader-Willi specialist homes, non-Prader-Willi specialist homes, and family homes. And they certainly show that the BMI is lower in the Prader-Willi homes compared to the non-Prader-Willi homes. Generally very good BMIs. This is probably related to the fact that actually they have a very good pediatric clinic in the same institute. So pretty well all the patients in the Netherlands go to this one centre, and so they're coming into adulthood very under good control, which is not so much the case always in this country. And we're currently collecting data from a number of European countries to hopefully show that Prader-Willi homes do have this benefit, with the hope to getting publications and hopefully maybe even affecting NICE guidelines to gain approval for these specialist homes to get more smooth access to funding for the homes. Sex hormones commonly needed in patients. About 3/4 of my adult patients are on testosterone. We recently had a review published in Journal of Clinical Medicine from a number of groups around Europe and America as to guidelines for treating hypergonadism in males. We tend to avoid the shorter acting testosterone injections that used to be the case, which would be given every sort of 2 to 4 weeks because they tend to cause quite high levels. And so we tend to start testosterone replacement with gels so we can titrate up the dose very slowly, and then switch to intramuscular injections every 3 months, or continuing on the gels as patients prefer. The reasons for not giving testosterone: sometimes patients just don't want it, and sometimes there have been concerns if people are maybe changing location of residence, or there are particular problems with behaviors. There are some concerns of exacerbating those behaviors with starting the testosterone. In my experience, though, as long as you start slow and build up gradually, that isn't the case. But obviously, if there are a lot of problems with behavior, one might want to wait until those behaviors have settled down until giving the testosterone. And the reason for giving the testosterone is primarily for bone strength, to avoid osteoporosis, but also to improve body composition, improve muscle mass, reduce fat mass, and also potentially improve cardiovascular outcomes over the longer term. I'll come on to this in a moment at the end. In women, the majority have no periods. Some have irregular periods. About 70% have sex hormone replacement, again for the same reasons as in men, to prevent osteoporosis. People can decide whether we want to give them periods or have intermittent treatment to cause periods. We tend to use low dose oral estrogen and increasingly patches and gels. These have the advantage of not having the increased risk of blood clots, which is a problem particularly if people are overweight and obese, and so we don't want to increase the risk of blood clots, and also they can increase the risk of blood pressure. So trying to use patches and gels as much as possible, and I'll come on to that at the end again. So growth hormone, which is now well established in children to increase final height, improve body composition, decreasing fat mass and increasing lean body mass, improves muscle strength and endurance, improves sense of well-being. It's now being started under 2, even under 1 year of age. Safety profile is reassuring. There is a theoretical risk of worsening blood sugars, but that can be watched for. There is no evidence that it makes scoliosis worse. However, if people are particularly obese, have obstructive sleep apnea or poorly controlled diabetes, one would avoid initiation of growth hormone replacement until these are treated. We don't yet know for sure how good it is in adults, and as yet in the UK it isn't licensed specifically for adults with Prader-Willi syndrome, although it is licensed for adults without Prader-Willi syndrome, and we can use the same guidelines to initiate treatment. And there may be long-term benefits on bone and quality of life, but we don't necessarily have that data. So when I see a adolescent who's been on growth hormone as a child, once they've achieved final height, I would usually stop the growth hormone for a month and retest, because they may actually no longer be growth hormone deficient. And depending on what test you use, somewhere between about 10 and 60% of people will be low in growth hormone, which will justify us continuing with the growth hormone. If on a stimulation test the growth hormone is normal, we can't continue it because we don't have approval to do that. If people are under 25, NICE, the National Institute for Clinical Excellence, allows us to use growth hormone replacement to achieve peak bone mass, although there isn't evidence that in Prader-Willi syndrome that is helpful, but that we believe there are other benefits other than just bone mass. But in Prader-Willi syndrome, we believe that there are benefits for body composition in terms of increasing muscle strength, muscle mass, and reducing fat mass. Whereas in non-Prader-Willi syndrome, the indications for Prader-Willi syndrome so growth hormone replacement after 25 years of age are in terms of psychological improvement in quality of life. And there is a questionnaire score called the AGDA questionnaire, in which people need to score above 10 at baseline and decrease by at least 7 over around 9 months or more to justify continuing it. However, this is a very crude questionnaire of yes, no, and isn't validated in Prader-Willi syndrome. And so we have to sort of almost play the game of continuing with it. So in terms of the potential benefits in terms of body composition, motor function, and potentially cognition are unclear in Prader-Willi syndrome. And we don't yet know whether there are benefits over and above what we believe to be the case from what we're allowed to prescribe the growth hormone for, which is basically just psychological improvement, which isn't validated as a assessment tool in Prader-Willi syndrome. Often, however, we do notice that when people stop growth hormone, either for the testing over a month or certainly longer term, that there is a deterioration. And so it's important to monitor any changes, with at least this questionnaire. So at least if there is a deterioration, that we can say, look, that they've got worse, and can we restart it? Sometimes there is some evidence to suggest that even if they pass the growth hormone tests, there may be a benefit for growth hormone, but it's difficult, if not impossible, in the UK to prescribe growth hormone in that situation. Sometimes we find people have the low serum IGF-1. So IGF-1 is hormone produced in the liver by growth hormone stimulation, and we use that to guide the dose of growth hormone. And sometimes we find people who pass the dynamic test but actually have low IGF-1, and then we're caught, can we give growth hormone in that circumstance? We're not under NICE guidelines able to do that, but of course there may be some benefit. And the response to growth hormone may depend on their current body mass index, whether they've had growth hormone in childhood, the adequacy of replacement with other hormones such as sex steroids. And certainly in non-Prader-Willi syndrome situations, we need to ensure that people are on adequate other hormone replacement before we assess any benefits of growth hormone. Certainly, if on growth hormone, there is uncontrolled progression of obesity, worsening sugar control, despite non-excessive growth hormone replacement, i.e. the IGF-1 level is within the normal range, or any worsening of obstructive sleep apnea symptoms, we need to stop growth hormone, and also in children, stopping at final height but retesting. So that's sort of the advice more for children than in adults. Certainly, we need to monitor people on growth hormone regularly, monitoring their blood pressure, their IGF-1, their cholesterol, their presence of diabetes, their other hormones, looking for side effects, monitoring their bone density, possibly every sort of 4 to 5 years, assessing bone density. We don't really know how to assess quality of life in Prader-Willi syndrome. We don't really know how to assess physical performance in Prader-Willi syndrome. Certainly in children, we need to do sleep studies before and after starting growth hormone, and we advise doing that in adults as well, to make sure that there's no worsening of obstructive sleep apnea, although that's probably more of an issue in children than in adults. So in my clinic, about half are on growth hormone as adults, about half had growth hormone as children. And in the meta-analyses where they've reviewed all the studies of adults with Prader-Willi syndrome, as I said, there is evidence that it improves body composition, increasing muscle mass, decreasing fat mass, reducing body fat, even though the overall BMI may not change. There may be, as I said, a subtle worsening of blood sugar control, but that's usually transient. However, there's only a small number of studies. There isn't a lot of evidence on bone density, muscle function, behavioral and cognitive status, and quality of life. And so in these small studies, assessing whether a subgroups, i.e. whether or not they were deficient in that dynamic test at baseline, or whether or not they had growth hormone as a child, it is unclear. And so we really do need some more studies on that. Underactive thyroid is certainly seen in Prader-Willi syndrome and needs monitoring. More of a problem in younger people than in adults. It may be something like 20% or so. There is a bit of a problem with the screening for this, is that, so normally an underactive thyroid in the general population is most commonly due to an underactive thyroid itself, what we call primary hypothyroidism, where the thyroxine level is high, and then the level of TSH, so that's the hormone that comes from the pituitary gland, goes up in an attempt to try and compensate for it. But in Prader-Willi syndrome, another potential cause is having an underactive thyroid, not due to the primary problem being with the thyroid, but being the problem being due to the pituitary gland not producing this TSH hormone that stimulates the thyroid gland. And one of the problems is when this is screened for by GPs generally, they only test the TSH hormone, that's the hormone from the pituitary gland, which normally is raised if you have an underactive thyroid. But in some cases, particularly in diseases like Prader-Willi syndrome, both the thyroid hormone and the TSH may be low. And so if you just measure the TSH, you may miss an underactive thyroid. It's not a problem when I requested in the hospital, but often, and it was something that came out during the pandemic, where we tried to ask the GPs to do blood tests to screen at least yearly, as I think you need to do for an underactive thyroid. They would just do the TSH, and that comes back normal, and they go, well, everyone's thyroid is normal. But in fact, really they need their thyroxine level measured as well as their TSH, and that can sometimes be difficult in primary care because they don't have a contract with the local pathology labs to measure both TSH and thyroxine levels. They're just measuring TSH, which in the normal population would be fine as a screening tool because TSH deficiency is so rare. But in Prader-Willi syndrome, it does need to be both, and that can be difficult to do. There was a concern a few years ago of adrenal insufficiency, that's steroid insufficiency in Prader-Willi syndrome. It's very dependent on what test you do, and there had been a concern from one particular group in the Netherlands, but really more recent data has shown this to be very rare. And in a large study that we recently did in a number of European centres, we found only 1.2% of adults with Prader-Willi syndrome to have a low cortisol level, and in a review of 650 adults, none of them had had problems with undiagnosed cortisol deficiency when, for example, they've been stressed, such as having surgery, and 200 had gone through surgery without steroids with no problems. So it really doesn't seem to be a problem. There was concerns that everyone needed screening for it. We don't really feel that is now necessary, only if people are displaying symptoms of hypoadrenalism, low steroids, such as particular lethargy, hypotension, abnormal sodium or potassium levels, or unexplained low blood sugars, that we need to screen for it with appropriate tests. Thin bones are seen, as I said, in our case, about 20% of cases, with about 35% having slightly thin bones. Many patients are coming through into adulthood with a degree of scoliosis. I certainly always screen for that with an x-ray when I first see them, just so we've got an idea. You know, it can sometimes impair lung function if the scoliosis is quite severe, and it may be missed just by examining people. Vitamin D deficiency, very common in the general population, and even more so in people with Prader-Willi, where sort of almost 90% are frankly deficient or have slightly low levels. Important to replace it at least 1,000 units a day. Calcium as well, if they have less than 3 portions of dairy a day, or there is actually thin bones. Certainly may need more if during the winter, where there's less sun, because we make vitamin D from sunlight in our skin, or if there's obesity, because people with obesity have low vitamin D, and they may need high dose prescribable vitamin D every 1 to 2 weeks in many cases as well. This is a nice study from the Dutch group of their adult clinic, showing that when they first see the patients, how many problems have been missed. So the numbers in black are the percentage that have a diagnosis of these problems when they arrive, and then in grey is the extra percentage when they actually screen for it. And as you can see, 43% have been found to have a low sex toys that isn't known about, 40% vitamin D deficiency that wasn't known about, 20% had scoliosis that wasn't known about, less commonly diabetes, low thyroid, high blood pressure or high cholesterol, but still warranting treatment. So it does need proactive screening for these problems in adults, because they may be missed, and that's despite even in the Netherlands having a very good pediatric service. Some of that may be because of being under child services. They're not always screening for things like hypercholesterolemia, high cholesterol, but it just shows you that it is important to actively screen for these problems. Sleep disorders are a problem. in many adults with excessive daytime sleepiness, and we screen for that with questionnaires. And if people score high on that, we certainly arrange sleep studies to rule that out, because they may benefit from non-invasive ventilation at night. Occasionally we see patients with narcolepsy and cataplexy. A couple of patients, that's sudden collapses due to under emotional situations like laughter leading to collapse, or narcolepsy where they will fall asleep suddenly. Can sometimes be a problem. I've had a patient who sort of fell asleep in the shower and broke some bones, and will need referral to a specialist neurologist involved in sleep, as they may need specialist treatments, medication to help with that. And there are a lot of problems contributing to sleep problems in Prader-Willi syndrome, including the hypothalamic dysfunction, poor muscle tone, facial shape abnormalities, in children at least, enlargement of the adenoids and tonsils, although usually they will have been taken out if there was a problem in childhood. Obesity itself that causes a problem because of excess fat tissue around the neck. There may be abnormal responses due to the neurodevelopmental disorder to low oxygen or high carbon dioxide, leading to a failure of breathing arousal, and abnormalities in breathing, especially in the context of obesity, where there may be restrictions to breathing. I'm not going to go into it, but there's lots of different contributions to the risk of heart and lung disease in people with Prader-Willi syndrome, including the obesity from hyperphagia, the poor muscle mass, leading to obesity related breathing problems, sleep apnea, the risk of blood clots, and increased blood pressure in the lung circulation, the risks of diabetes, high cholesterol, high blood pressure, although thankfully people with Prader-Willi seem to be slightly protected against these compared to people without Prader-Willi syndrome. Medications may not help as well sometimes, and some of the behavioral problems. So there's a lot of things that we need to tackle to prevent cardiopulmonary disease, which probably remains the major risk factor for early death in people with Prader-Willi syndrome. Other rarer causes of death, and unfortunately we still continue to have deaths from our adults with Prader-Willi syndrome, include, in addition to the cardiorespiratory problems, breathing problems, sudden death, the risk of gastric rupture and necrosis may be related sometimes to people who've lost weight and then have episodes where they eat very large amounts, and because of the reduced vomiting and the pain insensitivity don't usually present. And so certainly anyone presenting in Prader-Willi syndrome with abdominal pain or vomiting needs to be taken seriously, and consideration made as to the risk of gastric or even intestinal rupture and necrosis, and also increased risk of choking as well because of the hyperphagia and a variety of other underlying conditions that predispose to that. Bowel problems are very common, and some degree of gut dysmotility, constipation, bloating are very common. I commonly prescribe probiotics, particularly this one, Biocult, 2 capsules a day, which is often very effective in improving bowel symptoms in Prader-Willi syndrome. Tend to avoid lactulose as a laxative because it tends to promote bacterial overgrowth, which is not a good idea, and we tend to use Movicol and Dulcolax instead. Occasionally we have people with delayed gastric emptying as well, which can cause problems and sometimes need some medication. And because of the gastric abnormalities, there is this risk of gastric rupture, which has been seen, unfortunately has caused deaths in some cases. And certainly you can download from the US Prader-Willi syndrome website, and I think it's on the UK Prader-Willi syndrome website, a sheet for taking to accident in emergency departments to educate them in case they're not aware of those risks, because they can often present without signs, without a temperature, without a white blood cell response, or without pain, but actually have quite serious pathology going on, and should be a very low threshold for doing CT imaging of the abdomen in people with Prader-Willi syndrome who present with increasing abdominal pain and certainly with vomiting. A couple of lastly new recent findings that we've had is certainly showing the benefits of collaboration between Prader-Willi syndrome centres. So we've set up recently the International Network for Research Management and Education on Adults with Prader-Willi syndrome, called Informed PWS, and this is a a bunch of primarily endocrinologists looking after adults with Prader-Willi syndrome in Europe and also in Australia. And we've been pooling together our experience of managing adults with Prader-Willi syndrome to see what other things we've missed. And a couple of things just to highlight that have been revealing. One is the risk of a low blood sodium in people with Prader-Willi syndrome. And we reviewed the data from 1,300 patients with Prader-Willi syndrome, of whom the vast majority were adults. And we found that 2.6% had at least one episode of mild to moderate low blood sodium. That's between 125 and 135, with 135 generally being the lower end of normal. Sometimes it's 133. It's often multifactorial, so many causes, but the most common causes are some medications, such as carbamazepine, that sometimes uses behavioral control, which can lower the sodium, and also some selective serotonin reuptake inhibitors like citalopram, fluoxetine, which can also cause a low sodium. Sometimes it's excessive fluid intake. Sometimes people with Prader-Willi are reluctant to drink, but sometimes they will drink excessively. And so that can be a risk factor, especially if in combination with medications. Sometimes it's been due to high blood sugar causing a low sodium, and often no cause was found. These milder ones generally not being symptomatic, occasionally might be a little bit of nausea, but otherwise generally well tolerated. However, there were 7 adults, 0.5% of adults, who had severe low sodium, that's less than 125. 5 completely recovered, but unfortunately 2 died of a low sodium. The causes were, in some cases, 2 cases using a hormone called desmopressin. So that's usually given as a nasal spray, and that is the hormone that causes the kidneys to hold on to water, and it is sometimes used to prevent nocturnal bedwetting at night, and we certainly suggest that should now never be used in people with Prader-Willi syndrome because of the risk of a low sodium. In a couple of cases it was due to excessive fluid intake. In one case it was due to this low steroid hormones, and so a low sodium would certainly prompt screening for a low sodium. In some cases it was diuretics, water tablets, sometimes used for lymphedema, and in one case unknown. So certainly we should be avoiding the use of desmopressin in people with Prader-Willi. We should ensure that we're also inquiring about fluid intake and making sure it's not excessive. And there should certainly be routine monitoring of sodium with routine bloods, whether that's once a year or however often they're doing. And certainly if they're on at-risk medications such as carbamazepine or selective serotonin reuptake inhibitors, it should be checked. And finally, another thing that I'd noted this certainly in a few of my adult patients, was a raised prolactin called hyperprolactinemia. So this is a hormone that's produced in the pituitary gland. It's involved during pregnancy and milk production, and we've found 45 adults amongst our clinics who've had a raised prolactin. Obviously, not all the centres were measuring prolactin all the time, and so it isn't being done routinely. But in those, including mine clinic, where we measure it routinely, it was initially found in about a fifth, and that's not insignificant. In by far the majority of cases, it's due to medication, 2/3 of which just over half is due to antipsychotic medication. So that's medication like olanzapine, risperidone, which are well known to cause a raised prolactin. It was higher in those with maternal uniparental disomy, which is probably because of the association of maternal uniparental disomy with psychotic illness, meaning that they tended to be on antipsychotics more commonly. Normal is about, it depends whether you're male or female, but somewhere between 300 and 600, so a big variation in levels. Only 3 had very severe increase in levels. 1 of those had kidney dysfunction, which can raise prolactin, and only 1 had a very small growth, benign growth in the pituitary gland, which doesn't necessarily need an operation or anything, it just needs monitoring. Certainly it can be caused by larger growths, but those weren't seen in everyone, but admittedly not that many people had scans. All my patients, I had about 10 or 11 patients, all my patients had scans, and I haven't seen a growth in any of mine, but it is theoretically a risk. So certainly prolactin should be part of the monitoring. Now, what does prolactin do? Well, if you have a high prolactin, it can contribute to lowering of the estrogen level in women and progesterone levels in men, but of course it's lower anyway. And so we tend to to treat the sex steroid problem rather than giving a medication to lower the prolactin. Medications that lower prolactin can also sometimes lead to behavioral problems, and so we certainly need to be cautious if we are considering those, and none of these patients needed it. We don't treat the level, we treat the problems resulting from that level. If a prolactin level is raised, it can also cause milk discharge from the breasts, but that wasn't a problem in any of the patients that we had, indicating it's not likely to be a problem. But certainly it needs monitoring, especially if people are on antipsychotic medication, and that would usually be part of a psychiatric management anyway, as part of routine care, even if people do not have Prader-Willi syndrome. Some interesting new guidelines produced from the Dutch group on how to manage medical problems in adults with Prader-Willi syndrome, and the indications for that are worth looking up in terms of vitamin D replacement, hormone replacement, need for sleep studies, DEXA scans, spinal x-rays, cardiac evaluations, and certainly if there is problems with ankle swelling, shortness of breath, or poor exercise tolerance, as our patients get older, we may need to check that there isn't heart failure. There are some blood tests we can do, but they may be unreliable if people are overweight or obese, so we have to be cautious there. Screening for diabetes, cholesterol, high blood pressure, and screening for adrenal problems if there is symptoms suggestive of it, but not routinely. So to summarize, it is a multi-system disorder that needs a lot of management from different teams and appropriate referrals on. The management of the obesity remains control of the food environment, with increasing benefit evident for Prader-Willi specialist homes. The real life benefits of growth hormone replacement remain unclear, but certainly that there's likely to be a benefit in some. Breathing problems remain an issue and need screening for and treatment, and a risk of heart problems need careful monitoring for. Any organ can be affected. Increasingly, we find problems with the gastrointestinal tract that we need to be being aware of, and really need to do general health screening in all our patients. Now, I was doing it anyway, but many centers were not necessarily, but we should be doing at least yearly monitoring of blood sodium and prolactin. I'm hoping, I haven't spent a lot of time going into the drug trials, but there are some drug trials looking promising, and more to come, and hopefully we will see some benefits coming, and hopefully some drugs licensed soon. Thank you.
Tony, thank you very much indeed.